you're not speaking, you could keep your video camera off and your device muted. That we've found has helped with some of the meetings, because otherwise it affects the speed of streaming plus the sound quality. So if you could do that, I'd be very grateful. If I from time to time look to my right, it's because I'm looking at my iPad, which has got the agenda on it, because I'm not clever enough to put it on one machine. Other than that, let's start. Joe was going to be with us this afternoon, but unfortunately now can't. So we have a number of the execs on the meeting, and I'm sure that they will come in at various times, and we've got a number of the non-execs present as well. So welcome to all the governors. Has anybody got any declarations of interest they wish to make? No, I'll take silence as a no. If anybody, for those of you who are able to, there is a little hand sign on laptops which you can use to raise a question. Please use that if you can. If you can't, feel free to. Okay, there's one from Alan, who's now taking it off, so he's practicing. And if you want to use the chat facility, that is another way that we'll try and pick up questions as we go. As I say, I know this is a difficult form of communication. I'll try and keep it as precise as sort of precise and as I can, so that we can go through things quickly. But if you do wish to ask questions, then please do so. This is a formal Council of Governors meeting. So let's start with the minutes of the Council of Governors meeting on the 12th of February. No formal meeting was held in April due to the pandemic. And any comments or questions from anybody on those minutes? Okay. In which case, in terms of matters arising, working party, I think the chairman's report is around the constitution, and we will be restarting work on that now that we are getting through the worst of the pandemic, and hopefully the performance dashboard for month 9 was circulated, as it's now somewhat out of date. So turning to chairman's items, not very much from me, just some points to make governors aware of. So the new chair of the ICS, Rima Makarim, has started and has already organised 2 meetings, and there are a few more already in the diary. So she is starting to try and energise the ICS, but recognising very much, and I think people on it recognise very much, that there are 2 ICPs, which are Milton Keynes and then Bedford and Luton. There's also been an Eastern Region Chairs meeting, which I attended virtually. As people will probably imagine, most of the agenda on that was on COVID. So if I come in with any comments, I will do it during the COVID-19 report. It's fair to say that I think as a region, the Eastern Region has performed pretty well, and certainly the hospital within the Eastern Region has performed very well as an overview. I do want to mention a letter that was received from Amanda Pritchard, who's the Chief Operating Officer of NHS I/E, dated the 6th of July. And the reason I want to do that is because it focused on restarting sort of more normal life, but specifically talked about governance, and was very clear that as far as NHS E&I were concerned, they wished to continue with virtual meetings, and face-to-face meetings, both of board and of governors, were to be avoided. They also raised the issue of annual members meetings, and at the moment I don't see any way that we would be able to hold that annual members meeting in September as a proper meeting, and therefore we are looking at how we can best organise that from a virtual point of view, and we will keep the governors up to speed as to what it's looking like. And I think that is the approach that is going to be taken by most organisations that have members. So that was really all I wanted to say, because there's quite a good chunky agenda that we have now, and so we'll move on to that after. John, do you want to come in and say anything in relation to the Chief Executive's report as Joe is not with us?
Thank you, Simon. The The only two items which I think are worth picking up are actually on the agenda, which is COVID-19, which is supposed to be picked up by Emma, but she's not around, and I'm hoping to give Ian some advance warning that he might like to say a little bit about COVID in the trust, and about Restart, which I would suggest that we pick up under the performance report. But unless any of my executive colleagues have some burning issue that they would like to share.
No, that seems a sensible plan. And to give Ian a little bit more time to think about what he might want to say on COVID-19, I'm going to switch 3.1 and 3.2 around and ask Danielle if she could do a BAME update for us. This has clearly been a topic of some interest and issue over the last few months due to the pandemic. So Danielle, can I hand over to you?
Yep, thank you, Simon. And hello, everybody. I'm Danielle Petch, the Director of Workforce, for those who haven't met me before. So we've had a number of data requests, a lot of interest over the last few weeks, asking for information relating to staff data in terms of ethnicity, people testing positive for COVID, as well as patient data. So the first thing I'll say is that we are working through those. And we do plan to publish what we are able to publish on our website. So that will happen over the coming days. So do keep a lookout there for those of people on the call who have asked for various different statistics. I can share from an HR perspective some of the statistics around the staff. So we have about 33–34% of our headcount from a BAME background, and that's about 1,600 out of just under 4,700. So we are representative of the community we serve. Although having said that, inclusion is something that we are passionate about, and we are working hard to make sure that we continue to be representative of from all walks of life in our staff base. In terms of what we've been doing, particularly in COVID related for our workforce, from the very early on in the pandemic, we started to do thorough risk assessments. We followed the advice that was available at the time from the Faculty of Occupational Medicine, and that's been updated as the pandemic's continued. So we are adhering to NHS employers' guidance and following the Faculty of Occupational Medicine's advice on risk assessments. So the risk assessments we've been doing take into account a number of factors. They include medical conditions, age, ethnicity, area of work. And from those risk assessments that are carried out by managers, if it's felt that someone is in what we call the clinically vulnerable or extremely clinically vulnerable categories, which are people with a particular set of conditions or are working in a particular area or over a certain age, they then come through to the trust panel, where we make an assessment as to whether the member of staff should be moved to a lower risk area, work from home, or continue as is. So whether the risk assessment's done locally by the manager, and in most cases that's sufficient, so the employee and the manager have a discussion around all the factors that could influence them individually and in the workplace, and if necessary, reasonable adjustments are made, whether that's moving to a different area of the department, or whether nothing is required over and above the regular PPE that's needed in that area. So the personal protective equipment, so masks, gowns, gloves, visors, etc. So the risk assessments have been quite topical. There's been a lot in the press around them. We were asked, as all of the NHS was recently, to prepare to publicise the numbers of risk assessments we've been doing. There's been a requirement for us to do 100% of BAME colleagues at risk, and most recently male colleagues as well. Luckily, we were ahead of the curve on this. So since March, we've been holding risk assessments and holding the panel on a daily basis. We've done through the panel, which are the second stage risk assessments I've just described. We've done approximately 1,000 of those. So out of a staff base of about 4,800, I think that's a significant number in terms of those that have come through to the second level at panel. And our managers have recently confirmed that they've done 100% of the manager risk assessments in their areas. So it wasn't mandatory. Not every member of staff had to have one. People could choose not to have one. but we have done 100% of those people who wanted to have one. To make doubly sure of that, I did write out to everybody as well on by doing the payslip attachment this month, just sending everybody the risk assessment form, so that people have one final opportunity, one final reminder to do the risk assessment with their manager if they haven't already. So I think that's been a fantastic piece of work, and the teams across the trust have worked really hard to deliver that. So that's a good news story, because it's allowed us to be assured that we've taken into account all our conditions and circumstances for all our members of staff, and all team members are working in the area best suited to them individually at the moment. On top of the risk assessments, we have been actively engaging with our BAME community. So myself and Joe did a series of listening events where people could, very much like this meeting, but people could just choose to join and ask any questions they wanted. They were very well received and really helped us to listen to the worries and anxiety and questions and queries that staff had. Most recently, we've agreed that we're going to form an inclusion leadership council across the trust. So you may be aware that we have a number of staff networks already. So we've got a BAME network, an LGBTQ+ network, a women's network, a disability network, and we've recently been approached about forming a faith network. So our idea is that we will form a council with the chairs of those networks. It'll be chaired by Simon, who is our chair. I will be deputy chair. Alongside the representatives from the networks, we'll ask for a representative from each of the different staff groups, from the underrepresented groups. And we will use that meeting to discuss any board papers that we think may be of note, any papers from operational committees, management meetings. So it'll be another avenue, another way that BAME colleagues can feed back to us around decisions that are being made, pieces of work, projects, initiatives. So another really valuable engagement route. Most recently, you'll be aware that we are now bringing people back at the end of the month who have been at home shielding, and we're putting lots of support in place for that as well. So more listening events, people are forming support groups. Obviously, some of these staff have been at home for 3 or 4 months now, so coming back into the workplace after that time can be a scary thing. So we're helping them through that, providing reassurance that the trust has moved on significantly since the beginning of the pandemic. As you can imagine, people who've been at home for that length of time working from home can sometimes feel it's a worry to have to come back. So all the changes we've made, providing reassurance that we have considered all their needs, and so on an individual basis, people can be reassured that it's a safe and a good workplace to return to. So I think I've got some questions, Simon.
Yeah, Danielle, I'll come in first and then go to Akin. So one of the questions raised by the chat is one of the governors is aware of a pregnant employee who's feeling vulnerable and is getting stressed because there's not sufficient office space for social distancing.
Okay, so pregnant employees up till 28 weeks can stay in the workplace, but they need to be away from patients. So we have moved a number of people throughout the risk assessment process if they can't be accommodated in their existing work area because the patient makeup is wrong or there's not been a physical space. We have allowed people to work from home, or if that's not been possible in their role, we have facilitated them to do other jobs temporarily so that they can still do some work, but from a different either office or or from home. My advice to the pregnant employee is to talk through that with their manager. So there will have been a workplace risk assessment done in their area. Each area did have an assessment of the environment, and also to fill in a risk assessment as well for the workforce risk assessment and send it through to panel. If they can't be accommodated in their own area, we would look to move them somewhere else. After 28 weeks, the government advises that they should go home until their maternity leave starts. So we've been supporting that.
Just a quick follow-up. So if unable to work from home and no cover for work, presumably if someone is vulnerable and we carry out an appropriate risk assessment, if the outcome of the risk assessment was not to work, they wouldn't come into the hospital.
No, so if, for instance, they were in a role which couldn't be done from an admin area, then we will move them temporarily into another role. So we would find them some admin work to do, and then somebody else would cover their work for them.
Okay.
So can I just add, I suspect that this is the first governors meeting since the policy or guidance change around face masks as well. So office environments and other areas within the hospital, it's a requirement to wear masks unless a risk assessment has been completed to determine that area is safe and social distancing measures can take place to allow masks not to be worn.
Thanks, Mike. Akin.
Thanks, Simon. Thank you for your clear presentation. More specifically, I wanted to ask about provisions to protect people from bullying and harassment, because you didn't really cover that area. And that was, I think, what necessitated the questions I sent to Simon.
Okay. So in terms of bullying and harassment, we have a strong stance at the Trust that people should be able to come to work and be themselves and should in no way be bullied or harassed. We have detailed policies around that. People who feel they need some help, there's lots of either informal networks, so peer-to-peer support, or talking to the HR team or the management team or the Freedom Speak Up Guardian. If people want to do something more formal, so having tried the informal route, they still feel that they're being bullied and harassed, we have strong policies around that, and the HR team are supportive of anyone who wants to take that forward. We have recently introduced a fair and just culture, which means rather than try to go straight to a formal process, we do try mediation first and informal routes of resolution. But if that's not successful, then we do move on to formal cases. And that's the same no matter what ethnic background someone is from. All of those support mechanisms are open to them.
Okay, so will you be putting all this up on your website, so as part of your report that you were going to put up?
So we were going to put up the data that's been requested around patient numbers where we can, staff numbers. In terms of policies, we wouldn't usually. I don't think we usually publish our policies on the public-facing website. I'm not sure, but equally, I could send through the bullying and harassment policy. That wouldn't be a problem.
All right. Thank you.
Thank you.
Danielle, any more that you want to say at this stage?
No, I think I've given a general update on what we're doing in relation to BAME staff and COVID, and generally in terms of our inclusion, our new inclusion steps going forward. So happy to take any other questions, but if not, then no. Thank you, Simon.
Any further questions for Danielle? Can't see any.
Well, I'm going to step out now, if that's okay, Simon. So nice to have met you all. And if you think of anything afterwards, please just let me know.
Thanks, Danielle. Ian, COVID-19 report update.
Excellent. Well, I've had a bit of thinking time. So I think probably Ian Reckless, Medical Director. So probably if I give a bit of a sort of summary of what the COVID experience has been like for the hospital so far and what it's like at the moment. From our perspective, it's been going on for an awful long time, in that we had a warm-up period when we looked after the 100+ people who came back from Wuhan province at Kent's Hill. So COVID's been top of our agenda really since early February or late January. In terms of the degree to which the hospital was impacted by COVID, we have, touch wood, been quite lucky compared with some of the neighbouring hospitals, and certainly compared with hospitals in the northwest of England and also in London. And our worst months were essentially end of March into April, and it's becoming, say, for the last 5 to 6 weeks, things have been much more settled. So at its peak of COVID, we did very well in terms of working with CNWL and the council, and indeed families and patients, to discharge patients where possible. and CNWL were able to step up the care. They were able to provide the kind of therapy they could provide along with the counsel in people's own homes. And we were able to free up quite a lot of adult beds. So we've been in a very unusual position over the last few months of having additional capacity for adults in the hospital. And in terms of pressure points, ITU, or the intensive care unit, was essentially the pressure point for us. Ordinarily, we would have, typically we have 9 physical beds in our normal ITU, and that's typically staffed to have 7 patients or thereabouts would be our normal expectation. And in a normal week, maybe 1 or 2 of those patients would be having a ventilator or breathing machine doing their breathing for them, and the other patients would have other needs but could breathe on their own. So with that as our baseline, we went to a position where we were well above double with that. So we had, I think, at peak, 13 patients all requiring ventilation through a ventilator or breathing machine, and all of those patients at one point had COVID, which was a huge challenge for our intensive care team. From a doctor perspective, it was okay because anaesthetists in particular have skills that are quite transferable to intensive care. We weren't doing much in the way of planned operating at that point, so lots of our anaesthetists were able to step into ITU and assist. From a nursing perspective, it was much more challenging in that the ITU nursing team is a relatively small team, and the transferable skills are less obvious than they are between the doctors in those groups. But we had a great effort essentially with nurses from our practice development team, nurses from some of our acute medical unit areas, and also nurses from ED, who went to the ITU and worked alongside full-time ITU nurses and did a really great job. And many of you would have seen the Ross Kemp documentaries, which I think showed the hospital in a good light in really difficult circumstances. But I think it did show effective team working and people working outside their traditional comfort zone, but doing it safely. So in terms of the toll so far, and I'm very conscious we're not out of COVID yet, and there could be further peaks at any point. In the trust, so in terms of patients who've come into the trust and had tests for COVID, we've had about 600 positive tests over the whole period. And I'm estimating here probably about 150 of those will be in staff and 450 in patients, I suspect. But more importantly, and obviously more measurably, 117 of the patients who tested positive for COVID with swabs subsequently died in hospital. So the 117 deaths following a COVID swab. There are some people who would have a negative COVID swab but still have COVID. So the swab isn't perfect in terms of its pickup rate, and those patients would have a typical picture for COVID, and their X-ray and CT scan results would be very typical for COVID as well. And there were probably another 15 or 20 patients who we think did die from COVID and would have had death certificates saying precisely that, but had negative swabs. So that's sort of the scale of the 45,000 people nationally dying of COVID. Probably around 130 died in our hospital. If we look at staff, clearly there's been lots of different sort of focuses on testing at different points during the pandemic. But there was a time when we were asked to test our staff. So we tested several hundred staff one day, and these were staff who felt well and were at work, so they didn't have any symptoms. And on that particular day, 3% of staff had COVID. Now, if we did that again today, I'm quite sure it'd be much, much lower because the peak in terms of the community background has also fallen. But we did swab staff on that particular day. Probably more importantly, we've done some antibody tests, which means taking blood samples and seeing if the person has had exposure to COVID, not just in the last few days, but potentially in the last few months. And we have done antibody tests on approximately 2,500 members of staff, so probably getting on for 70% or so of our staff. And 19% of our staff have had previous exposure to COVID. So at some point over the period, roughly 1 in 5 of our staff have had COVID. Now, again, in terms of the actual level of COVID in the hospital today, I think it's going to be an awful lot lower than it would have been 6-8 weeks ago. Right now, in terms of patients coming into the hospital, we have only had 2 patients test positive for COVID in the last 2 weeks or so. So the number of patients coming in with active COVID disease is really quite low, and fingers crossed it will stay there. Now, what we're trying to do is keep a really, really close eye on what we're seeing of COVID in the hospital, but more importantly, what's being seen in the community. and there are now other ways of being tested for COVID. So if you go to sort of a drive-through and get tested there, those swabs don't come through our laboratory and we don't instantly see them. So you'll hear in the press people talking about pillar 1 and pillar 2 testing. Pillar 1 tests are the ones that are done through the hospital. Pillar 2 are the ones done in the community and sent to the commercial labs. And clearly what we'd like to be able to do is really see the detail of that information and work out where in Milton Keynes, if anywhere, we're beginning to see early signs of an outbreak. And we're working really, really closely with the council and with the public health team in order to try and bring the data both from the hospital and the community together, so we have an early warning if there is any sign of an outbreak. And at the moment there isn't. So right now Milton Keynes is in good shape, but I'm conscious it's not very far to Bedford, and Bedford is probably number 13 or 14 in the country in terms of density of COVID at the moment. And we've obviously all heard about Blackburn and Leicester and so forth. So really what we're doing in the hospital now, recognising there's not much COVID at the moment around, is trying to organise things such that we provide a safe environment should there be more COVID, such that we make sure that patients and staff aren't able to transmit it between each other. So infection control measures and distancing, and also trying to get some of our more routine services back up. And again, nationally, we've heard that the number of referrals from general practice to hospital fell off a cliff in March and April, so about 80% down on what it would normally be. And in some ways, that's an A&E attendances fell as well. And in some ways, that's good news. If there were people who previously either didn't need to come to hospital or weren't getting any benefit from coming to hospital, then it's, I guess, no bad thing that they're no longer coming to hospital. But there are also an awful lot of people in those numbers who would benefit from attention. And clearly a specific example is patients who have some fairly soft symptom to start with, but a symptom that could mean cancer. And the number of patients coming to hospital with potential cancer has been very much reduced. We'd assume cancer has been happening in the background as it always would have done. So there's presumably an unmet need in the community. And we're really encouraging patients to feel safe to come to a hospital to access testing. We've been one of the first hospitals in the area to restart the screening program for bowel cancer and breast cancer and other forms of cancer. And we're currently in a position where we're probably running at about 45–50% of a normal efficiency in terms of our planned operations, so hip and knee replacements and other sorts of operations. And we'd hope to be shifting that up towards 70 or 80% as we go through the summer. So we're some way behind in terms of efficiency, and we're conscious that there would have been a significant backlog of patients building over the last few months. And one of the obvious ways of seeing that is in those patients who've been waiting for over 52 weeks for treatment. And we're now in a position where I think 90 patients have been waiting for over a year for services from the hospital. That's clearly not a satisfactory position. Many of those patients, it wouldn't be appropriate to treat them during the COVID period, but nonetheless, having waited 9 months before going to COVID was too long. So we're working on those things. Simon, I wonder if maybe taking questions might be better than me droning on.
Thanks, Ian. Alan, do you want to come in? You're on mute, Alan Hancock.
Connection. I'll have to.
Here we go. Is that it? Anybody?
Okay.
Can you hear me?
Yep.
Good. Yeah. In view of all the bad. Well, no, first of all, I was thanking Ian for his report, which was very good. Thank you. And what I was going to say was that if there's this concern that our people are not coming because they are worried about getting COVID, can some of what Ian's been telling us be put into a relatively small report, and then get the comms people to find ways of getting that out to the public in Milton Keynes? I mean, one thing, for example, is I'd love to get it for our surgery, for our PPG. So if some of that information could be made available, that would be great. Thank you.
So Alan, I'm sure we can do more of that. Clearly, it's already happening a bit via the hospital website. But I completely appreciate there are lots of other avenues to get messages to people. I think one of the things I probably should have mentioned is from when we first heard about Wuhan, which was somewhere I hadn't heard about before, but from then till now, we've been working so much more closely with partners in the local authority and with GPs and with CNWL. I think relationships across the system and beginning to get a sense of having one health service rather than lots of different organisations. We made huge steps in the last few months. I've been working quite closely with GPs and speaking to large groups of GPs most weeks now, and I think that they would also be happy to help get that message out.
Thanks, Ian. Other Alan Hancock, do you want to come in?
Yes, please. Remind me to change my name, not to me, Alan. And later, I'd just like to say something about the minutes, which I wasn't able to say before because I wasn't able to connect at that time. But while Ian is here, the 3 questions which are not necessarily directly related to COVID, but I'll group them together. The first is, have you had any problems recorded in the experiences after the return of some of the outpatient services, examinations like endoscopy, for example? I ask because I know someone who, well, it was okay in the end, but it was a little bit getting back to normal in a slow way. Secondly, what impact is it likely to have if the contract for the private hospitals is not renewed as far as waiting times are concerned, as the Treasury doesn't want to spend the money on it? And thirdly, I wondered if there are any changes in procedure and protocol that you've introduced during COVID, which you're thinking that you're likely to retain because they've actually proved beneficial over the longer term.
Okay, thank you, Alan. So taking those in turn, I think 2 things about endoscopy. The first one is endoscopy is probably the procedure intervention that's most affected by COVID, and that's because one of the major risk factors for transmitting COVID is something called an aerosol generating procedure. So if I was to make somebody sort of cough and splutter all over me and to be fiddling around with the upper airway, that is far more likely to get virus if it's there out and about and into the room and infecting people around. So in endoscopy, there is a very major focus on the level of personal protective equipment that staff wear. There's a very major focus on cleaning between cases, more so than usual. And that essentially means that endoscopy services nationally will probably be running at about 50 to 60% efficiency compared with normal. And most endoscopy services, to be honest, are under some pressure beforehand. So there are, again, one of the, I'm not sure it's an advantage or disadvantage of being on the boundary of various different regions, but we seem to be on regional calls about endoscopy capacity in one region or the other several times each week. So there's an awful lot of attention to that. Something we're doing is there are some indications where you can either have an endoscopy, particularly looking at the lower bowel, or you can have an X-ray test, a CT test. So we are shifting more patients towards CT than we would have done before COVID. And also in terms of your friend or acquaintance's perspective, I'm very conscious from a patient perspective, things are really quite different. So firstly, patients are inevitably and understandably more anxious about coming to hospital. Now, right in the last few weeks, I suspect coming to hospital has been as safe as it's ever been, but when COVID prevalence goes up, then I understand that anxiety. But also patients are being asked to do things differently before a procedure. Now, if you're coming in having an operation under general anaesthetic, you are contacted more than 2 weeks beforehand, so at least you're listed with some advance notice, but you're asked to completely self-isolate for those 2 weeks. The only time you're not self-isolating is when you come to the hospital a few days before the procedure, ideally in a car, you roll your window down, you get swabbed for COVID, and then you go home again. And only patients who are both negative for COVID and who've been self-isolated for 2 weeks are getting their procedure. So it's a major undertaking. And if you think, for example, I don't know, a child having grommets inserted into their ears, for example, that would be a child not at school, isolating at home completely for 2 weeks, and both their parents, all of them being swabbed, etc. It's a huge undertaking. In endoscopy, we're not doing the swabbing, but we are doing questionnaires and isolation. So it's quite an onerous procedure, and recognise that's difficult for patients and families. Moving on to your private hospital question. So the national government essentially procured all private hospitals in the country and asked them to do NHS work. In some areas of the country, that's proving really, really very effective and helpful. I was speaking to a colleague from Oxford today, where the local private hospital is getting through an awful lot of NHS work and is doing a great job. In Milton Keynes, we are working closely with both Blakelands and also the Saxon Clinic, and we are doing what we can to get whatever patients we can to those 2 venues for procedures. So we are doing some work at both places. But we're not getting through vast volumes of patients. And the key reason for that is that lots of our patients, certainly those who've been waiting for longer on waiting lists, tend to be higher risk from an anaesthetic perspective and therefore have to be done in a hospital with an intensive care unit. So if you've got a big private hospital with an intensive care unit, then happy days, they can get on and do all sorts of different procedures. But in Milton Keynes, both the private providers are really quite small scale, and therefore we're quite limited in the sorts of procedures we can do. So yes, we're working with them closely. We're getting some patients treated in those venues by our staff, but it's pretty marginal in terms of the impact on waiting lists. So we'll carry on with it, but we really need to get our own theatres up and running to full efficiency. And then worryingly, I can't read my own writing, but it was changes, I think, was the last thing you mentioned.
It was a question of the changes in procedure and protocol that you've had to make during COVID. Are there any of them that you're likely to retain over the longer term because they've actually proved beneficial? Yeah,
so I think there are probably three things. The most obvious one is the use of technology. So across the NHS for years and years, we've been trying to use technology for interacting with patients and to improve the efficiency of services. Milton Keynes has been more advanced than many other places. But over the course of COVID, the whole of the NHS has shifted to technology overnight. And we've essentially got on and done things in a couple of days that would previously have taken us many months of arguing about to decide whether we were going to do it from an information governance perspective or various other perspectives. Now, clearly, we've gone too far in some ways. I don't want 100% of our outpatients to be seen via a video conference, but I'm confident now that almost all of our clinicians have experience using video conferences and telephone consultations. And I think we'll get to a position where services have the appropriate level of virtual consultation in them. I think that will be to benefit to everybody, but do recognise that many patients still benefit from face-to-face interactions. I think the second thing would be, over the years, we've become, in medicine generally, become much more specialised and subspecialist. And I think one of the positive consequences of COVID is that specialists essentially went back to being generalists. So doctors and nurses have been mucking in with each other and supporting each other and willing to work in different areas. And I think that's actually been really, really healthy and positive. So if, for example, the nurses who went back to the intensive care unit to work with the intensive care team, when they're no longer needed in the intensive care unit, they will be taking those acute skills back out to other wards, who will become more confident about managing monitors and various other central lines and various other sort of high-end things that we should be doing on some of the wards, and historically we may have concentrated rather in one or two wards. So it has helped share some of the skills around the hospital. There'll be other examples, I'm sure, but those are the two that come to the top of my head.
Thank you.
Thanks, Ian. Any further questions for Ian? No? Okay. Let's move on to the digital update. John, are you going to pick that up?
Simon, Julia's been trying to get in for some time. I don't know if she's...
I think that's Alan Hastings who's got Julia's laptop, and the hand has just disappeared because I think he asked his question earlier. It was confusing me as well.
Okay. Right, so digital upgrade. The last few weeks we've been trying, you all have seen, and I know many of you use MyCare to understand appointments and get information from the hospital. We've been moving it along over the last few weeks, and we just wanted to report back to you that a couple of things have happened. Firstly, for some time we've had the option for patients to indicate that they were happy to receive electronic communications only rather than paper communications, and we haven't actually been in a position to do that. But we have now turned that on, and so for patients who are using MyCare who have said that they are happy to receive electronic communications, we are now sending appointment letters and electronically to their app, and they will get a text telling that they have got a new letter. We're going to go one step further over the next 2 or 3 weeks and start sending what internally we call copy letters. These are letters that are written by clinicians after an outpatient appointment, sent to the GP and copied to the patient, and those letters too will go directly electronically to the to MyCare so that they can be read and stored and reviewed as necessary. And we intend to make further changes over a period of time to those digital services. But I know that some of you use it, and I think generally we've had good feedback. We have some concern that there are many patients who still use their fridge door as the principal way of remembering that they've got an outpatient appointment, and perhaps don't use electronic diaries on a regular basis. So we want to make sure that, for example, our DNAs don't go up. So we'll be monitoring those sorts of things carefully. But I think it's a step forward. It saves us real money because each letter that we send saves us about £1, which can now be spent on other clinical services. So all in all, I hope it's good news. And I can see at least one positive response in the chat. Maxine.
Hi there. Yes, I think it is a really positive move. One question I have is about the content of the letters themselves. So they seem to have been very slow at changing from when people are having face-to-face appointments, or traditionally face-to-face appointments, where they've moved to a virtual setting. People have been telling us, and I've experienced it myself as well, that we're still receiving letters that say you're expected at the hospital here and what you need to do to put those in place, and then being told very late in the day before or that morning that your appointment has changed to a telephone consultation. And that has been quite slow. And those letters that are still coming through the post are just uploaded into that into the patient portal instead. So there's something about how that patient portal can be intelligent to do more live updates to actual practice in the hospital and appointments. Does that make sense?
Yes, it makes perfect sense. I mean, the reality is that we had something like 5,000 different letter templates that were stored inside our patient administration system, and it has been a gargantuan effort to try and rewrite them. So we have been trying to do that, and we are making significant progress. But I absolutely hold my hands up and say that we have had many occasions when we've sent a letter which is not very helpful out, and sometimes positively misleading. I hope we're getting better. There are more enhancements that are coming over the coming weeks, where the actual letter itself will contain a link to a video conference facility, which I think will again be very good news. So hold my hand up. It hasn't been perfect. We should be getting better. We should be better than we were, and we're going to get even better over the next few weeks.
Fabulous, thank you.
William.
Yeah, just a couple of points. Just to, first of all, to reinforce that one about kind of, templates obviously not being necessarily updated and slightly out of date, because I think that clearly has caused some concerns and issues. But just a couple of other points. There are still facilities which have still to be, made live. So currently you can't change a date and time. Currently you can't cancel an appointment. Currently reports aren't available. I'm just wondering what the time scales. I know, that those aren't necessarily haven't been priorities at the current time, understandably, but I'm just wondering what sort of time scale there might be for adding those additional facilities.
So those facilities exist now for many of our services. I had a fracture clinic appointment myself, which I actually cancelled this morning, right, on the app. And so they exist for many services, but not necessarily for all services. Right. And therefore, I don't want to get into specifics with you, but it may well be that it's a service that we haven't yet got to. But right, for many of our services, those exist already. And Kate and her team are rolling out services as fast as we can, because we recognise that not only patients get informed, and actually, I don't know about you, but the post isn't quite what it used to be, yeah. And so it is quite nice getting almost instant communications electronically.
Yeah. No, I suppose for me, probably the slightly more pressing one is the fact that reports aren't available.
When you say reports, what sort?
Well, things like test results.
Okay, so the laboratories are working. I don't think there's any diminution. I can come back to Ian about that in terms of the turnaround time for normal testing. And so the results should all be available, Ian. I'm not aware of any problems.
Well, all I can say is they're not, certainly on
GP or from the hospital?
Sorry?
From your GP or from the hospital?
From the hospital. I'm talking about on the portal.
The pathology results don't. When you say the portal, do you mean renal? No,
I'm simply talking. We're talking about the patient portal, as I understand it.
So there are no pathology results going into the patient portal.
But one of the things listed as available is see your test results. That's listed on the blurb about how it's going to be effective.
So John, I think the intention is that the test results will be made available. I think it's something that's not yet live within MyCare.
Absolutely not.
And I think there's a question on the timings of that. I don't know whether we have a definitive timing. I know there's lots of governance requirements around releasing test results and lots of discussion with clinicians.
Right, I understand.
It may be something, John, we want to come back to when we're looking for a definitive timescale for that.
Okay, thank you. Thank you. That's helpful.
It's coming over the next 2 or 3 months.
Okay, thank you.
Yeah, I think the point is well made that it's aspirational rather than present at the moment. So we should try and reflect that in the language on the portal.
Yes, indeed. Thank you.
Alan?
Yes, I don't want to bore you, but just wanted to say that we're coming up to the first anniversary of the renal results not being available through patient view.
Yes. So this is something, sadly, we've Ian and I have been around this this loop. This is something that only Oxford can resolve. So sadly, we can't do anything to help them.
Yeah. And I've also the Renal Council, the Renal Association, because I'm on the patient council, trying to get at least something put on the website which has simply said for a year that it's not available because Milton Keynes isn't uploading them, and there is no indication of when this situation will be resolved. I've tried to take this, escalated it up, down, sideways, whatever direction, and absolutely nothing ever changes.
This is Oxford. I have little sway over them, sadly. Any other questions?
No, I can't see anything. So thanks, John, for the update. Give you a quick breather before estate development and PALS, which I think Michaela is going to do for us.
No,
it's going to be Julie.
Fantastic.
Thank you, Julie.
Hi there, everybody. Thank you, Simon. And thank you, Alan, for inviting me to come and talk about PALS and complaints. Thank you. I've actually got a presentation, so I'm going to try and share it, if you can bear with me. Right, I think that's just loading. Can you see that presentation? Yes. Yeah. That's great, thank you. Right, so as I say, I'm Julie Goodman and I'm the trust lead for the complaints and the PALS service. I've been at Milton Keynes Hospital now in this post since 2008, so I've seen it all and done it all at the moment. So I think what was interesting when I met with Alan was the people just talk about PALS and weren't necessarily aware that we had a complaints team as well. So just to confirm, we've got 2 teams. We have a complaints team that's in Oak House and opens 9 till 5, Monday to Friday. And the PALS team is down in main reception, opening to the public 9:30 to 4. And the various contact numbers were on the slide that I've just taken off by mistake. Sorry about that. So
there are two differences to the offices, and I will come on to that. But firstly, just to talk about what a complaint is. So a complaint is any expression of dissatisfaction made to an organisation, i.e. us, either written or spoken, whether justified or not, which requires a response. So there is absolutely no difference in my world and in our complaints world between a formal and an informal complaint. Both of them are, a token of dissatisfaction on some part from the by the complainant or the patient or the family. So from our policy, so locally, that was the Patients Association definition. Our policy definition is much the same: expression of dissatisfaction made about an act or admission of the hospital, either verbally, writing or electronically, whether justified or not, which requires a response which cannot be given by the end of the next working day. So that is, when we have a complaint, if we're able to respond and resolve that within 24 hours, we don't have to report it as a complaint. We report it as a comment or concern. But those ones are also logged on our complaints database. But as I say, we're not nationally reporting those, so you wouldn't hear about those ones in the reports that I produce for Trust Board. So what I've said here is why a complaint's important. And this came from Andrew Lansley, who was the Secretary of Health at the time, who talked about instead of seeing complaints as a burden, something else to do, another investigation to do, that we should learn from our complaints, learn from our mistakes, listen to what our complainants are telling us, and evaluating our performance and seeking to improve. So that's what we try to do when we take complaints, whether they're through the PALS team or the complaints team. So we absolutely encourage complaints and feedback. We want everybody to tell us if things didn't go well. As I say up here, they're like gold dust, so they're free to us. People give their thoughts willingly in often 6 to 7 page letters. And they also have some good ideas about how we could improve and what action we need to take. So we make it as easy as possible for our complainants to contact us because we do want their feedback. So they can contact either the complaints team direct or the PALS team. And then the most appropriate team, as I'll come on to, will actually deal with the issue. So they can usually come to see us in person. Obviously, we don't have any direct face-to-face contact at the moment, but they can call us, email us, and telephone us as well. And we are just in the process of setting up a team availability for people who do want to actually physically see us as such, and that we can have meetings that way. So just a thing I wanted to say here, because this is always causes a little bit of confusion really with staff, is to say that the Complaints and PALS service is a patient-led service, and staff cannot insist that a person contacts us to make a complaint. It has to be the complainant's choice. So a member of staff can actually tell people about PALS and inform them they're there, but they can't ring us and say, you know, I'm having trouble with a patient, can you come and see them? That's not what we're about at all. We're very much patient-led. I've just included in this slide something from Roy Lilly, I'm sure you're all familiar with, where he says the complaint system will work when we make it easy to complain and lessons learned, etc. So going back to what I was just saying, that's absolutely what we try and do. And obviously at the moment, we're struggling with that a little bit with the PALS service not actually physically being open face to face, but we're doing all these other contacts. So the main question was here, what I wanted to get over was the difference between PALS and complaints. Because very interestingly, when I met Alan, he was saying that he didn't really realise there were two teams and he didn't know the difference. So crucially, both teams deal with complaints. The fundamental difference between PALS and the complaints office is that what we try and do is make sure that PALS deal with those issues that are happening here and now, or have just happened very, very recently. And we try and work with the staff and the complainant, the patient, to try and get that resolved so they go on to have a good experience. So that can be an issue that is not very severe, or it can be an issue that could be quite severe, and we need to intervene and try and make that better experience. The approach is different because the approach from PALS is quite an informal one. So we'll talk to the patient, the complainant, we'll talk about what the issues were, what they want, and we're boundary, what we can with that, or what outcome they want. And then we work with staff to try and achieve that for them. Whereas with the complaints office, they deal with the formal complaints. So these might be complaints where people particularly have written in or have come to meet us, and there's no immediate action that's going to change the actual what has happened. That unfortunately we can't undo that, but what we can do is listen and learn and investigate. And these often involve issues over a period of time, perhaps. And usually they are issues where perhaps some moderate or severe harm may have been caused to the complainant, to the patient, sorry. So those complaints that they're often multifaceted as well, across a number of departments and a number of specialities. They do take a long period of time to investigate formally, and are subject to a formal investigation and a formal response, which is actually signed off by Joe Harrison. So just to say that Joe Harrison does see all of our complaints and signs all of our complaint letters off. So PALS also does a lot of other stuff, and they do get sort of tainted with just dealing with complaints, but they also do an awful lot of other stuff. So we signpost people to the correct service. We find out in the world of CCGs and CNWL and GPs and dentists that they don't have this service. So when people have a complaint about those services, they think automatically we own those services and want to complain or want some information through us. So we very much signpost people to the correct service and make sure they get to where they need to go. And we've also just, if anyone has looked on our PALS page on the internet, we have just added a whole load of signposting information around the most common issues we usually get asked about, and we've put the contact details on there. We provide information, so some people will just be quite anxious and they'll call us to say, where do I park, how do I get to X-ray, and those kind of issues. We deal with the compliments, of course, which are coming more so than the complaints, and we make sure that they get, with the Kayla's team and the Chief Exec's office, we make sure they get shared, and everybody knows about those compliments and who receives them. Those people are told. And we also receive feedback. Some people might just want to come in and say to us, do you know what, I've thought about what my experience was like, and it would be better if you could do X, Y, or Z, and that could be anything really. And so then we'd put those feedback, that feedback to the department and see if they could take that on board to improve the experience for our complainants. So I mentioned a little while back about the severity of a complaint. So we have the 4 severities there. So every complaint that comes into this organisation, whether it's through the PALS route and informal, or through the formal route and goes through the formal process, it's what we call triage by myself and the deputy chief nurse. So we triage them in one of these 4 categories. And going back onto my description of PALS, we would normally expect PALS to be dealing with the yellow and green, the no and low harm complaints, and the formal complaints to be the ones where severe or moderate harm has happened. So, however, I just want to put a little caveat to that if there was something at this moment on a ward happening and it was on the face of it appearing to cause moderate harm, PALS would be involved to get that quick, get in there and get with the staff and sort the issues out with the patients and complainants. Sorry, I think I'm talking quite fast, aren't Just wanted to say a little bit around, we have a lot of guidance and regulation. So a lot of the things we do are guided by the national complaint regulations. So they apply to all NHS complaints across the whole of the country. And they lay down such issues as we have to acknowledge every complaint within 3 days. We try our very best in this trust to acknowledge within 24 hours, but we do have 3 days. And those regulations say that we have up to 6 months to deal with a complaint in its totality. And we try with PALS to deal with them as quickly as possible, and with the formal process within 30 working days. So we're well within those timescales always. We have everything we do, all our processes are governed by the Ombudsman's principles, the way we treat people. We have a trust policy that covers our processes. The CQC are obviously very interested to look at complaints, how we deal with them, and most importantly, what we do about them and how we learn from them. And there's been lots of reports following the mid-staff inquiry, France's report, the Clwyd and Hart report, and an assurance of good complaints handling toolkit. All of those reports and guidance have very specific ways in which we have to deliver a complaint service, and it's all of there. A lot of that is all around the good customer service, which is obviously the background for most of my staff. Not least of all, we're also guided obviously by the NHS constitution. So there's quite a lot that we have to think about when we're going along this process. So the things that people complain about, probably not a shock to anybody, that communication is the biggest issue that we have. Patients or their loved ones not receiving information or understand what is happening. Lack of information, people feel uninformed about their care. Some people are saying to us that they don't feel they are dealt with in a compassionate way. There's some care issues sometimes, things like call bells not being in reach, or taking too long to answer. And then there are some complaints around the staff attitude, the way that patients and complainants perceive that they have been spoken to by a member of staff, which is a sad one. And then there's also those that come about resources, things like there weren't enough blankets or pillows. So these were our top in locally. So those issues I've just talked about are national issues across the board. But our local picture, these were our top 5 for last year. As you can see, mostly about communication again, about the attitude of staff, and a delay in giving results as well, which ties in with your conversation from earlier. So going back to the severity, the severity determines the level of staff that investigate our complaints. So green and yellow, so the PALS type ones would just go to a normal local manager for them to investigate and respond either directly to PALS or complaints and the actual complainant. Or the red and amber ones would be investigated by senior members of staff, i.e. a matron, a consultant, or an operational manager, and they are also copied into the senior divisional staff as well. Just a brief overview really there of what we'd be asking them to look at. We ask the investigator to look at what should have happened, what was expected, what did happen, and if there was a difference, we ask them to explain why there was a difference. And if something went wrong, what was the impact for that patient? And most importantly, what are we going to do to make sure this doesn't happen again? So what is our learning and what is our action and outcome? And what makes a good complaint response? I really don't need to go through all of these, but I will say that whenever we are dealing with anybody, whether we're a member of staff on the floor or we're a complaints member of staff, we always should try and put ourselves in the shoes of the complainant. Think about what it feels like, or it would feel like if that was our mother or our husband or our wife. and try and see it from their perspective. We don't know what they've come from in their home environment, what they're facing, what difficulties they're having. And it's just about trying to put yourself in their shoes and see it from their perspective rather than ours. And just think about how would you feel if what they describe happened to you or your loved one, how you would feel, and think about the impact that would have had. And when we're responding, we obviously want to respond in a way that we would like to get the response ourselves. So our letters need to be very clear. They need to be in plain English, not condescending in any way. And our responses that we give verbally, obviously the same rules apply. Sorry, that was a very quick whistle-stop tour through my world. I don't know if anyone's got any questions.
Julie, thanks very much indeed for that. I know Helen has a question if she wants to come in.
Yes, thank you, Simon. And Julie, thank you very much, as Simon says, for a comprehensive presentation. I've just got a question. It's really based on, there's much media at the moment in terms of the report that's just been completed by Julia Cumberledge et al. Around patient voice. And reading her report, it really did have quite an impact on me. And I just wondered, I know we do lots of patient stories, but I wondered if there has been any other thought around how we can really capture the patient's voice in terms of, when you read the report that Julia Cumberledge has just submitted, women particularly had been raising issues across the NHS, but actually we very little impact. And I just wondered how we could do something in terms of ensuring that we were assuring ourselves that we had strategies, processes, systems in place that actually provided that assurance for us as an organisation.
Oh, thank you, Helen. I'll probably bring Michaela into this to answer. So I work closely with Michaela's team, the patient experience team. So all of the information we gain from complaints, etc., are shared and triangulated with the information that comes in through other feedback, such as friends and family. So I personally, from a complaints perspective, I know one of my objectives, one of my managers at the moment, is what we're going to do is set up a goldfish bowl exercise to listen to complainants about what they feel about the complaint service, but also how they feel it could be better. So that way we will be engaging with inviting people to come to that sort of later when we're obviously past COVID, hopefully now. I don't know if I've really answered your question. I don't know if Michaela can.
No, that's helpful, and it's probably something that we need to get a bit more thought and explore a bit more. But I was just thinking about all the wonderful work that's being done in terms of learning disabilities and how we, I guess, incorporate that across lots of other different areas. And you mentioned Roy Lilly in your presentation, and he has actually done quite a lot of work on patient stories as well. And there's patient stories programs. I don't know much about them, but it might be something that we could explore or further in terms of how we assure ourselves in terms of getting that patient's voice.
Yeah.
Okay. Michaela, do you want to come in?
Thank you, Jojo. Thank you.
Hi, Helen. Interesting about the patient stories. NHS England and NHS Improvement have just started through the heads of patient experience network something called digital storytelling, which is around capturing and it's about capturing the essence of a story, but in about 3 minutes. And it's sometimes very difficult when you're speaking to a patient that can be very upset that they need that time to talk, and you might be speaking to somebody for an hour, but you've actually got to distill that into a 3-minute vignette of all of their deepest feelings and fears. So that's something that we're looking into. I think the thing around the Cumberland report, the women's network that Kate Jarman has set up, she brought that report this week, and it was something that we said we would discuss and explore. So maybe that's something we can bring to a future meeting, because there's a significant amount of really emotional information in there, and it's particularly relating to women's voices not being heard. And it's not just women's voices, like you said, the learning disabilities and people that don't speak English and that we don't engage with. And that's a part of the patient experience strategy, to look at the groups that we hear from less. And we should never use that term hard to reach, because it's about us going out and finding them and talking to them. So I think it's massive opportunities with the patient experience and the PALS and complaints team to take forward.
Thank you very much. Thank you.
Maxine, do you want to come in?
Yes, very quickly. The complaint system, I mean, we've heard obviously throughout the COVID-19 lockdown that complaint systems had really gone to the back burner for the time being, and I know that a lot of staff have been redeployed. The PALS team have been quite visible still at the entrance to the hospital, so it was just a little information about how you've managed complaints across from your green to red during that time, and what impact there is, and how you're recovering from that in terms of backlog around complaints.
Thank you, Maxine. Yeah, so nationally, the advice came to actually put a pause on the formal complaint process. So we did actually do that at the beginning of April there. And for all those complaints that were already in the system, we wrote to those people and people that were waiting for complete resolution meetings. We talked to them and informed them of what was happening. And where possible, we used, to finish off investigations, we used some of the staff that weren't able to work clinically to finish off those investigations for us. So we were still getting some of the responses out. The advice was from the 1st of July to actually take the pause off. As an organisation, we actually took the pause off the 1st of June, because we felt clinically we were able to do that. And I have to say, we haven't got a backlog. We have had complaints starting to come in. Not quite as many as we normally would have in the last 6 weeks, but probably about 75%. And they are going through the system and already being responded to. So in answer to that, I think we've dealt with it very well, and we continue to deal with it very well. And nobody has been really inconvenienced or upset or distressed by any pause. How we made sure that when they came in, if they came in through COVID, as I say, we triage everything. If there was anything here and now necessary in the ones that came in during that time, we actually got on and did that. And then, as you say, the PALS continued. The only thing they didn't do was face-to-face. But the other things that we did as a PALS office that you've probably read about is we set up a relatives information line along with some nursing staff. And that was a line for relatives to be able to phone in about their loved one. So they weren't going to the ward to take the ward away from the caring element. And we were giving information, well, the nursing staff were giving information. We also did letters to loved ones, and we continue to do that along with the relative line as well. So that is whereby patients and families could send in a letter or photos to their loved ones, and we delivered them to the ward laminated for the patients to read, and that's been hugely and well received by everybody. So I think that answers everything. So yeah, basically we haven't got a backlog, and we are getting through and giving those responses.
It does, thank you.
Thanks, Julie. Just one question that's come up is in relation to, you mentioned suggestions in the presentation. Presumably they wouldn't fall as complaints as such, and the opportunity is for people to provide suggestions via feedback boxes on the hospital website, or writing into PALS potentially.
Yeah, sorry, I've lost thread of what you said there, Simon. So
how will we treat suggestions, as opposed to it not being a complaint, more a suggestion for how we could do something differently?
Right, yeah, so we log them on our same database, but not as a complaint, and we would share them with the areas and whoever you know, we felt was necessary to share them with, and then we would feed back what the outcome of that was to the person that would give the suggestion if that's taken up. So that's what we do at the moment.
Fantastic. That's really helpful. Great presentation, and thank you for all the fantastic work that PALs do. They've been particularly visible, as you say, during the last few months, and have done a great job. So thanks to all of you and your team. Very much appreciated.
Thank you. Thank you for inviting me today. Thank you.
It's our pleasure. Take care. John, over to you and estate development.
Thank you, Simon. I too am going to share my screen. Hopefully you're able to see that. Okay, yes. Good. Splendid. Right, so I'm going to whiz through this at a fair old pace. I am looking at the chat box too, so if you've got questions which you'd like me to answer on the way, then please fill out the chat box. Hopefully you can see the screen moving now, because I've had a problem in the past with it, but if you can, I will continue.
We can see John.
Okay, jolly good. So this is what I'm going to go through. So first of all, it's about the healthcare program to replace hospitals that Boris announced some time ago, and Milton Keynes are one of the trusts that's going to benefit from this. Exactly how much we don't know yet, but it's going to have a profound effect on us. So this is our case for investment that we put to NHS IME, and this is what we hope and are planning to do over the next few years. So unlike most hospitals who are taking part or making their case on the grounds of hospitals falling down and backlog maintenance, we're really making our case to the centre based on population growth. And Milton Keynes is one of the fastest growing cities in the country, but actually, as you can see, there are others like Cambridge, for example, that's growing at say 15%, and Peterborough, for example, at 10%, and it's hard to put this into context. If you look at the BBC News, however, it was quite clear that whilst Cambridge has seen the largest growth at 15%, it amounts to about 7,000 houses, whereas Milton Keynes at 11% is actually nearly 12,000. And if you recast that diagram based on where the little circle, the pink circles are the size of the house building, you can see that Milton Keynes is very significantly bigger than Cambridge. And I don't know if you ever thought about this, but if you look at a city like Cambridge or like Oxford, they are probably only half the size of Milton Keynes in straightforward number terms. So Milton Keynes is actually a very substantial town. Now, Milton Keynes has had very significant success in delivering completions, about nearly 16,000 over the last 10 years, or 1,568 a year. That's going to go up as they move towards what they call the MK metropolitan area, and that's because some of MK is going to turn out not to be an MK, and up to about 2,900 homes per year, taking us to a population of say 400,000 by 2040 and probably another 100,000 by 2050. Those of you who can see those purple lines, this is the proposed mass transport system that the council are considering. So will it happen? The answer is really yes. I really do believe it'll happen. Milton Keynes is at the centre of the known universe. It is halfway between Oxford and Cambridge. It's halfway between London and Birmingham, and the house prices are probably half what they would be in either Oxford or Cambridge. So it's a very good place for people to live, and the housing developers are not short of land. And the houses, compared with other places, we might think they're expensive if you live in Milton Keynes, but actually they are incredibly affordable compared with other towns around us. Helen, you are requesting control. Whether you're doing that deliberately or not, I don't know.
No, I've got no idea what I did. I must have pressed something by mistake, John. I don't even have a little hand to wave on my toolbox. I don't know how that happened. Apologies. I don't want to take control.
Okay. good. It's usually only me that wants to take control. Right, so the effect on the trust. Let's just look at what effect this growth has on the trust. This is our increasing inpatient population as a percentage. So if you wind back to 2011, 2012, and you look at the growth, we've had nearly 30% increase in our inpatient growth in the last 10 years or so, last 8 years or so. And this is forecast just to continue. This is simply reflecting the population of Milton Keynes. And if you look at maternity, if you look at this graph here, the UK projected births has a long period of static or even slightly decreasing birth rates. If, however, after about 2030, if you look at the expected growth rate nationally and you lay on that and also the growth in Milton Keynes population, you can see that we'll be going from sort of 4,000 deliveries to 6,500 deliveries over a period of less than 25 years. An enormous increase that we are just simply not able to cope with. If you look at children, Milton Keynes has opened 7 new primary schools in the last 3 years. Children are up by about a third in the last 7 years in Milton Keynes. And for the first time last winter, inpatient children spilt into all sorts of areas they'd never been in before, and our occupancy against our normal full capacity was up at about 110%. We also get criticised for surgery, both in terms of some of the facilities we have, in terms of some of the theatres that we have, in terms of our inability to have ring-fence elective or orthopaedic beds. We have a day surgery unit which is now too small and not fit for purpose, and we're also spending about £4 million a year on having routine orthopaedic and other operations done in the private sector, which really doesn't need to happen. So let's look at our current estate. You will all know Oak House. This is the energy performance of Oak House. It is so fallen off the bottom of the scale. It's remarkable. And these are exactly the same energy performance ratings that you would see for your own house if you were to try and sell it or indeed try and buy a new house. This is an interesting picture. I hope you can see it. This is taken with an infrared camera from a drone and shows the hospital hemorrhaging heat. The 2 black spots are the newer buildings, the treatment centre, Ward 22. Unfortunately, we haven't got an up-to-date picture showing the academic centre or the cancer centre, but basically the whole of the site is hemorrhaging heat and is a really poor build. And if you try and understand why, this again is Oak House. Basically, Oak House is a pair of tin sheets with some loft insulation stuffed between them. And actually you can see that the loft insulation is not even staying put, it's beginning to fall. So this is rock wool insulation. It's beginning to fall, and so Oak House gets very, very hot in the summer and very cold in the winter, and is really a shockingly poor building that really should never have been built like that. So if we look at our response to date, as you will know, we've been trying to keep the site in good order, and we've done it principally without any NHS funding. So the main entrance, the academic centre, the staff multi-storey car park at the back, the Ward 24, which is sitting beside the treatment centre, which is a rented ward, some off-site accommodation in terms of Whitton Gate, and our beautiful new cancer centre, which is now open fully. The last people moved into the cancer centre a week or 2 ago. And whilst we have a risk-adjusted backlog maintenance at 12.7 million, that is absolutely nothing compared with some trusts, and there's at least one large London trust who has a backlog maintenance claiming very close to £1 billion. So this is what we would like to do to the site over the next 5 years or so. You will be aware of the pathway unit building beside A&E to help keep people out of the hospital, and to have a short stay ward on top of it. The MRI building at the back, close to the Eaglestone restaurant, has had a single MRI in it since our contract in 1999, 20 years. We want to knock it down and build a much larger imaging centre with up to 5 cross-sectional scanners and all sorts of ultrasound in there. But we also want to build a new surgical block so we can repatriate the work that's being done outside of the hospital, and build a new women and children's hospital, which will take care of the growth and provide a service that's genuinely fit for the population. The other one is radiotherapy, where we are getting closer and closer to an agreement with Oxford and Specialised Commissioning that there really ought to be a radiotherapy building, probably with 2 bunkers and a planning CT next door to the cancer centre, and we have started the design work for that. There's lots of work for Mike and others to do in terms of the form of the contract. So there is that work to do. Now, an interesting question's popped up on the chat about with the experience of COVID-19 and the need to change what was looked like. So we are aware, and interestingly, we had a phone call with the Department of Health and the East of England region this morning over the design, and they are also aware that the design of hospitals has to change to reflect the challenges that were given to us by COVID. It's not quite clear to what extent that will change, but certainly possibly more single rooms, or the ability to chop departments up so that they can have a COVID side or a non-COVID side. And I'm only using that as shorthand because who knows what health challenges will arrive over the next 20 years. There are some more boring stuff that we have to do in terms of all the new building that we want to put in place. Currently sits on car parking, so we need to just dispose of that once and for all and build a 3rd multi-storey car park. Office accommodation, originally we planned to repatriate most of it on site. We still plan to do that, but one of the changes that has been introduced from COVID is working from home. And I think our requirement for office accommodation is going to be significantly lower than it was before. And Danielle and other colleagues are working on how we make sure that our staff can work safely and happily from home. We're also talking about primary care hubs and a community hospital, by which I mean really a bedded facility to step up or step down patients. So this is the current site development control plan, starting at the top with radiotherapy sitting beside the cancer centre, radiology, by which we mean the imaging centre where the MRI building is. The Women and Children's Hospital will almost certainly sit on the car park, which is between A&E and Oak House. The pathway unit you are aware of, which is going to sit beside A&E. The admin block, I don't know whether that will ever get built or whether we will find a way of not needing it. Multi-storey car park and hopefully a 3rd exit out of the hospital out this way onto Saxon Gate. The new surgical ward block sitting where the education centre is and the old CRS building, the porter cabin up at the top of the site. And the idea at the moment is to repurpose about 56 bed spaces where Ward 14 is, and the ward next door, which is currently used for offices, into a lovely community facility. So the pathway unit we've talked about, we finished the detailed design work, we're out to planning. Mike has nearly sorted out all the funding for it, and this is going to be about a £20 million building. This shows it as being 3 stories. There's an option for a 3rd story. I'm not sure that will ever happen. It'll probably stay 2 stories. The imaging centre will look something like this, and it takes the place of a single-storey building that exists. Current costs are about 15 million, and it could house up to 3 MRI scanners and 2 CT scanners, and keep us in first-class imaging probably for the next 20, 25 years. The surgical block and the Women and Children's Centre, we've only currently done in terms of these sort of block designs, so we can see the sort of services that are going to be in there. We've just appointed some professional advisors to help us write what's called the strategic outline case, which is the document that starts the funding process. And we've been given a grant of about £1 million to help write that document. But we will, over the next few weeks, start consulting with staff and experts here about what should be in these actual blocks, about the clinical adjacencies and what needs to be where in terms of making sure the whole site works for patients. And also we must start engaging with the general population about these exciting new opportunities, and specifically with interested parties in terms of the patient experience and the view of the patient in terms of accessing these services. This is a picture of the Women and Children's Hospital, and we're hoping to put some things in which we simply haven't got at the moment, things like an adolescent unit, as well as a midwifery-led unit. So there are lots of exciting things. We hope and expect that we can deliver all these buildings for about £230 million. And there is a commitment that we've given the Department of Health that the Women and Children's Hospital will be open in some way, shape or form before the end of this Parliament. So this is actually getting quite difficult to deliver, because although that 2024 sounds like it's a long way away, in terms of these big buildings and spending, more than £100 million, it is going to take a while to build them. Those are the project costs. We don't need to go into those. And in terms of governance, the redevelopment board will report in up to the trust board, and we will obviously keep the Council of Governors updated on a regular basis. And that's all I wanted to say.
Thanks, John. Any questions for John? I guess one of it is, in terms of funding, this is dependent on funds being signed off and allocated to us. And
yes, all the noises at the moment are very positive, you can always be blown off course, but I think that unless something else happens, I think that this is a better than 50-50 that this is going to proceed, and we will be given a large sum of money to proceed. I don't know if Mike has a view on that.
So I think there's a high degree of confidence. I'm not overly concerned.
Julia, okay, Alan?
I think it's Alan. Yes, Alan Hastings.
Very quiet, Alan.
Do you want to come in?
You're on mute. You're on mute, Alan.
Right, let's try again.
That's it.
Right, I've forgotten the question. Will governors or other patient representatives be involved in some of these designs and so on?
Yes, I think I made that clear, that we will involve both patient groups and as well as, actually, I want to engage with the general population as well in terms of their imagination. I'm sorry?
It was awful. It was a complete waste of time.
I think someone's not on mute who should be. Okay. So yes, and also with we have to engage with commissioners. We'll want, obviously, the view of people like Healthwatch in terms of pointing us at the right sort of groups who can feed back, and we want to take this as an opportunity to put right some of the wrongs that, in terms of changing places, for example, that this is an opportunity while we create space to make sure that these buildings are fit for everybody and not just fit for most people.
Thanks, John. Can't see any more hands or anything in the chat. So thank you for that. Very comprehensive presentation, and we'll keep our fingers crossed.
Thank you.
So moving on to assurance summary reports for committees. So I'm going to take these by exception, really. So first one is the Finance and Investment Committee meeting, 1st of June 2020. Does anyone have any comments that they would like, or questions they'd like to ask in relation to this? Next is the Charitable Funds Committee meeting, 10th of June 2020.
Can I just say something?
Yeah, of course you can.
So I just say, I would have said it as well for the finance guys, but want to thank the teams, because I know sort of, for example, in the finance team, people have taken on board other roles, obviously, over the time. I think the governors should be aware. So I think Mike was taking a big lead on PPE, but also on particularly on the charitable committee. I mean, I think overnight they had to transform how they worked, as the report says, but I really think they did transform how they worked in terms of kind of making sure things that were being donated and given to the hospital were getting to where they were needed most in terms of patients and their families. So I think we should just all acknowledge the job that was done by the team there.
Absolutely. Absolutely agree.
Thank you.
Quality and Clinical Risk Committee meeting, 22nd June 2020. Brian.
So if I can come in there, one of the items appears to be this SME analysis. Looking at the graph, and it looked to me as though it was going out of control from sometime last year. The SHMI index that we are supposed to monitor, as I understood it.
So Simon, I can
shimmy.
So shimmy, I wonder whether we should pick that up as part of the performance reports, because with that same chart will be shown as part of that report as well.
Yeah, thanks, Mike. We'll pick that up then. Thanks, Brian, for the question.
Okay.
Simon.
Yeah.
Simon, can I just say that in terms of the Quality and Clinical Risk Committee, we are having a seminar between now and the next, in terms of just looking at more detail, patient experience and pressure ulcers. So I just wanted to provide more assurance and so forth. So just wanted to let everybody know that.
Thanks, Helen. Audit Committee, 22nd of June. I know Andrew has had to leave, but he had nothing particularly to highlight in respect to the Audit Committee. And finally, Workforce and Development Assurance Committee meeting, 4th of May. No. I would just take this opportunity to update the governors on a couple of changes to the committees. John Clapham has stood down from the board as a result of retiring from Buckingham University, and he was their nominee on the board. So he has retired, as a result of which we are seeking a replacement from the University of Buckingham for the board, which will come through the governors in due course. But secondly, Heido Hussain and John Lyle very kindly joined the Charitable Affairs Committee, on which John sat, and Helen has very kindly joined the Workforce Development Committee as well. So just to let people know that we haven't overlooked the need to keep our committees fully active. So the next item is Health Watch Milton Keynes. Two fascinating reports. I found the survey really interesting, and the annual report was just staggering in the amount of work that you managed to do, Maxine. So I don't know if there's anything you want to particularly highlight or comment on.
Yes, thank you. It's been a crazy couple of months to try and get our annual report together. You know, despite everything, we have a legal obligation to publish this report every year, and they didn't let us off. We could have done a much shorter version, but we felt it's such a shame with all the work that we'd put in place this year to really not showcase it like we normally would. And with social restrictions on events being what they are, we won't be able to have a big AGM this year to showcase what we've done. So hopefully this annual report gives some evidence to the public about and patients about what we have been able to achieve this year. I think the main thing from a hospital perspective is just to highlight the maternity enter and view visit that we made to the hospital. It has been something that we wanted to do for a long time. It was kind of part of our original enter and view plans when we launched in 2017. But there's always quite a lot of different things going on, you know, with maternity MK and walk the patch and things like that. So we finally found a window to come in and take an independent look at it. I think the difference with this report as well is we actually went outside, so kind of acknowledging that women and families having that experience on the wards at the time might sometimes need a bit of time to process that experience as well. So we followed it up with some visits to children and family centres so that we can ask a few weeks later how people still felt about the overall experience. You know, and no surprises, you know, generally the experience was really positive. People spoke really highly of the staff on the wards, and much of the improvements that came up for us were things that came up in Walk the Patch and other things, mainly around partners not having a lot of room, the temperature of the wards, you know, that they can be quite crowded. It's a bit of a shame in many ways because the world has changed around us since we did this, since the report was published. So it'd be interesting to see. I mean, we're unable to do enter and view at the moment, and look as things become safer, that, you know, the local providers such as yourself help Healthwatch to ensure that we can safely undertake enter and view as we used to. It'd be interesting to see what changes are actually made to experience on wards or certain pathways, particularly maternity. I hear that the women themselves are starting to get used to talking to each other rather than their partners. So, but you know, different experiences coming through really, and be interesting to see what happens in another year with the COVID situation. And with the COVID survey itself, I mean, that was a very responsive thing. We wouldn't normally plan to do a lot of engagement this time of year, wrapping up our annual report and doing our AGM. But obviously with the lockdown in force and with such changes people are experiencing with regards to the services that they're used to receiving, we thought it very important to ensure that people had the opportunity to have a voice throughout that process. And tried to send that information out. So we sent it out on kind of the results on a fortnightly basis to providers so they could see what was being shared. And I think from a hospital perspective, it was quite interesting to see the kind of demographics that we got in, that actually the majority of people who responded were female. We didn't have the kind of representation or proportion of people from BAME groups that we would have liked to see. You know, but that actually most were over 65 as well, which highlights that a lot of people are very digital over the age of 65, but that we, you know, perhaps again need to put some more attention on younger groups and how to engage younger groups in talking about sharing their experiences during this situation. And again, for the hospital, it was just those kind of worries around resuming normal operations, which has come up today, and helping people feel safe to access services again. And also the concerns about the impact of COVID-19 on those with specific conditions, and that communication around a lot of people have felt quite vulnerable whilst not actually technically in a shielded group. And how we could, certainly if we go into a second wave, how we can support people better with communication about their particular conditions. So unless there's any other questions. Then...
Any questions certainly from our point of view, the interim review report's been very helpful, and for all sorts of reasons, hope that you are able to resume them in the not too distant future. Thanks very much indeed.
Thank you.
Alan Hastings, Lead Governor report.
This will be extremely brief because I haven't done a lot, I'm sorry to say. On the 1st of June, I was supposed to attend a virtual meeting with the other lead governors in the area, but due to a few problems with my equipment and the arrangements that took place, I was unable to actually attend. Other than that, the main thing that I've done quite a bit of, excuse me, sorry, recently is review various leaflets and so on that the Trust have been preparing in different areas, which have been very interesting, and just reviewing them from a patient point of view. So Michaela's been keeping me busy. Thank you, Michaela. And that's about really it, I'm afraid. I just feel as though the lead governor's not been doing a very good job.
I think it's fair to say, Alan, you've been fairly restricted in what you're able to do, but I just so that the other governors are aware, you've sent me a number of emails over the last few weeks raising a number of different points. So the feedback that you're giving us is extremely helpful from my perspective.
Right. I think one thing I will say is, hopefully on behalf of the governors, is to thank the Trust and all the staff for everything that they've been able to do in this difficult time, and also today to thank all the people that have talked to us and so on, and made things very much clearer. So thanks to everybody.
Thanks very much, Alan.
But one final thing, all the best wishes to Maxine. I don't know whether everybody knows about Maxine's situation.
No, I don't think. No, it all got a bit secretive because of the lockdown. But I'm due to go on maternity leave in September, so I didn't really get to share the good news before the lockdown. And because of Teams, no one can see how big I'm getting. So yes, no, I'm expecting another boy, and he's due in early September. So I probably won't see you for a little while, but I'm working with Julia about having our Deputy CEO cover the governor's role in the meantime.
Well, congratulations, and hope
good,
everything
good
goes
luck
really
anyway.
Well. Thank you.
And thanks very much for your kind words, Alan. And yeah, I would
Okay.
re-emphasise, I think all the people at the hospital have done a fantastic job over the last few months, and the board is incredibly grateful to them. So that leads us on to the integrated performance report, and I will take questions on this unless there's anything you particularly want to highlight, John. Nope. Okay. Mike, do you want to come in on Shimmy?
Yeah, so just bear with me while I come to the right.
I could even...
Sorry, John.
Apologies. So just to say that the HSMR, which is doing well at 96.2, is in-hospital mortality rate, the expected in-hospital mortality rate. You're absolutely right to say that the Shimmy, which is the summary hospital level mortality indicator, is technically out of control. Now, Ian will, I'm sure, tell us that there are no specific clinical concerns about this. We believe that it's artifactual, and Mike and others and the information team have been doing a lot of work to try and track down exactly what has been causing this. I see Ian has come on screen.
Yep. So these figures, the Shimmy and the HSMR, are both based on a calculation that tries to look at how many patients would be expected to die at Milton Keynes, given both the diagnosis the patient is given, so if number of patients going heart attacks or bowel cancer, whatever else it might be, and also the general sickness and status of the patient. So things like age, deprivation, all these sorts of things are put into the calculation, and importantly, other illnesses a patient has, so their comorbidities. Now, we found over time that our ability to submit comorbidities for our patients to the system has become worse. So essentially, when we brought in e-care, we've become less good at capturing comorbidities, which we're trying to address. And that will account both for deterioration in the HSMR, which deteriorated about 2 years ago for a year and then stopped, and it was still better than expected. So we were reasonably relaxed about that. And the shimmy's been deteriorating over the last year. So it'll be about coding depth. It will also be about a couple of essentially administrative issues. There are some episodes of care that are submitted to this national data system which go uncoded, so there's no diagnosis at all attached to them. And essentially those are things we'd regard as outpatient attendances, which is why they're not coded. So there are various different technical complexities. We think we have a reasonable and developing understanding of what's gone on with the shimmy in recent past. And the reassuring thing is that the HSMR, the other metric, has stayed stable in recent months. And more importantly, every single patient who dies in the hospital, their case is reviewed, but now by a medical examiner who's a qualified doctor who goes through the death and ascertains whether or not there are any concerns for the family as well. And that level of assurance around the quality of care wasn't there 2, 3, 4 years ago. So it makes these statistics rather, in some ways, less powerful because we've got case-by-case qualitative data as well. But we are looking into it. I hope it will improve. Inevitably, any improvement will lag for several months, but we are onto it.
So other than that, Simon, perhaps we will just take questions.
Yeah. Questions? Brian.
What I'm also looking at is the apparent difficulty with discharges, and I'm wondering if this is related to any particular department, such as pharmacy, because we seem to have a lot of red on that section of the statistics. And when you look at key objectives, objective 4, we seem to have problems again. Is there an interaction between the two sections?
So in terms of discharge, there's certainly more work that we can do and are doing with pharmacy and others, because I recognise for patient experience, delays around TTOs are really frustrating. I think it's really important to take all of the discharge metrics and do quite a lot of our metrics with a rather large pinch of salt for month 12 and month 1 particularly, because the number of patients and the types of patients we've had in the organisation because of COVID have been so very different. So I think we'd be wrong to go down sort of a blind alley in terms of looking at some of the metrics for those specific months, but recognise the overall point around discharge.
Yeah, I appreciate that, Ian, and therefore I wonder, is there any way that the COVID-19 aspect can be separated out to give a clearer picture as to what is happening in the basic hospital context?
Yeah, so I think discharge is a good example. So for example, in February, March, April, May, June, the discharge of all patients has been totally impacted by COVID. So the law changed, the Coronavirus Act 2020 meant that when we say we'd like a patient to leave the hospital because they're medically fit, at least in theory, the system is legally obliged to react to that within 2 hours. Now, if we'd been asked, if we'd been told that was a possibility a couple of years ago when we had really significant length of stay challenges, that would have been brilliant. So the whole context has changed. I think we need to keep an eye on those metrics and also work with pharmacy and others to make sure we have better and more granular data around some of the processes, such as time to TTOs. So I'm not wanting to ignore it. I'm just conscious we need to very much be looking at these months for all patients as impacted heavily by changes due to COVID.
Yeah, obviously, if there is a record being made, it needs to be recorded how these figures are being affected. Not just for now, but if there were to be, say, a second wave, would there be some understanding, once again, with the statistics based on the experience at the moment?
So absolutely agreed. We need to have a health warning on our reports, and we need to be able to remember that in 2, 3, 4, 5 years when we look back at this either dreadful or great stuff that happened to our metrics in 2020.
Yeah. Okay, thank you.
Any further questions? No, can't see any. Okay, Mike, finance report. Anything you particularly want to highlight?
So yes, I will do a bit of an introduction rather than just take questions, because it's slightly unusual at the moment. So on page 81 and 82 of the pack, there's two summary tables, which is unusual. I usually just stick to one. I can't recall whether we've had any previous discussion at governance. I don't think we have around the new financial regime. So let me just summarise. So as a result of COVID, and in order to ensure trusts have sufficient cash flow at all times, the national team have varied the financial regime for providers and commissioners. So whereas previously we were paid for some commissioners based on the amount of activity we performed at a price per patient basis, and for others based on a block arrangement, so that was with Milton, Keynes, CCG. As a result of COVID, for this financial year, all providers are being paid teams by NHS England and NHS Improvement, and we're receiving that fixed amount instead of receiving amounts based on the amount of activity we're doing. And the national teams have also formed a view of what our costs are likely to be, or rather looked at what costs were historically and rolled those forward into the current financial year. And when they do that, we, like most providers, are left with a bit of a gap. And in order to ensure that we have enough cash, they provide a national top-up. So if you look at page 81, there's a summary table that shows the income position. That's largely fixed, what we receive under that block arrangement. There's an expectation or assumption around our pay and non-pay costs set by the national team, against which we've reported our actual costs. But if you go further down the page, you'll see a line that says national top-up 3055. So the national team expected that in order to break even, we would need just over an extra 3 million. But that didn't take account of extra costs associated with managing COVID. So lots of different costs. That might be covering sick leave. It might be lower levels of efficiency, requiring additional staff to deliver similar levels of activity. And this is the report for month 2. And what that shows is that as a result of COVID, the organisation had some additional costs over and above what had been assumed. And we put in a claim for an extra £700,000. And that was similar at month 1 as well. So all of that is designed, in essence, to get the trust back to a break-even position. And every trust and every CCG will be reporting a break-even position at the moment. That regime won't stay for the whole year. It's still being decided how that regime will change. But at the moment, we have certainty until the end of August that we, or rather end of July, but I'm expecting actually August to be included as well, that we'll operate on this national block sum arrangement with that might be somewhat confusing. It does make it very difficult for us to plan because the numbers have been set by a national team and actually money and activity are now somewhat divorced, whereas previously they've been closely linked. And what I suggest is once we get clarity on the new regime, I'll bring a paper to governors which sets it out in a bit more detail. The key point for today is just that we are being paid what is required to ensure we deliver a break-even position at least until the end of July, but I'm expecting that to continue beyond that period as well. That was a long way to say that little summary at the end, but if there's any questions, I'm happy to take them.
Thanks, Mike. Any questions? No? Okay. Thanks very much indeed, Mike. So before we finish, I'll just remind the governors that we have a very short private meeting after this finishes, and I hope it will be very short because there's only one item of business. But just to finish off this meeting, no motions and questions have been received from the Council of Governors. Any other business? I know Alan Hancock would like to come in on the minutes, which is an issue that he's picked up. Alan, I think you might are still on. Oh, I'm trying to. Yeah.
Okay. Yeah, I'm come through. Yes, two things. First of all, could you possibly circulate the slide sets that have been shown today? I think it'd be very, very useful. The one thing I wanted to pick up is really just for the record. I should have said it when we were looking at the minutes, but I lost sound at that point. It's a tale of two Allans, and it's a minor issue, but on those minutes, Alan Hastings and myself are known as AH and AHA, and we got somewhat mixed up. So that various things that I said were attributed to Alan Hastings and vice versa. Now, Julia and I have been corresponding and have sorted it out. Nobody seems to have noticed this anyway, because there were no comments on the minutes. But she is making the corrections, and they will simply be reissued. But it was such a technical issue that we didn't think it was worth reissuing it before we began this meeting. That's all. Thank you.
Many thanks, Alan. Does anyone have any other business? No. Okay. In which case, everyone who is not a governor may depart. And thank you very much indeed for all your contributions this evening.
Thanks, Simon. Thanks, everybody.
Bye-bye. Thank you, Simon.